Okay. Thank you all for being here today. I am very excited to introduce Dr. Nathaniel Morris. Dr. Nathaniel Morris received his medical degree from Harvard Medical School and completed a psychiatry residency at Stanford, where he was a chief resident. After residency, he completed a fellowship in forensic psychiatry at UCSF, and he is currently an attending psychiatrist for the San Francisco Jail Behavioral Health Service, where he provides care for incarcerated patients in the San Francisco jail system. And he is also an assistant professor of clinical psychiatry in the UCSF Department of Psychiatry and Behavioral Sciences. His academic interests include psychiatry and the law, mental health care in jails and prisons, and the criminalization of people with mental disorders and substance use disorders. He has published approximately 50 articles in peer-reviewed medical journals. In addition, his writing has been featured in a number of media outlets, including the New York Times, Scientific American, Wall Street Journal, and the Washington Post. Thank you for being here.
Thanks so much for having me. Nice to meet everyone here tonight. I'll be doing a very, very brief introduction into the field of forensic psychiatry. And I'm not that skilled at both talking and answering in the chat, but happy to answer questions as they come up, and feel free to interrupt at any time. So I guess we'll get started. So first, I don't have any disclosures, the kind of usual disclosures that, any opinions here, my own, not my kind of employers. This is obviously for educational purposes. So what is forensic psychiatry? I had not heard too much about the field when I was a medical student. I really didn't hear much about it until kind of the end of medical school or in residency. And so this is at least how, so the American Academy of Psychiatry and Law, they are kind of the leading organization, or one of the main organizations in forensic psychiatry in the United States. And they would say forensic psychiatry is a medical subspecialty that includes research and clinical practice in the many areas in which psychiatry is applied to legal issues. So a very kind of quick and dirty way of thinking about it is really just the interface between psychiatry and the law. That's often how I kind of conceptualize it. So an important thing as well is to think that, and here they add in their kind of definition is, while some forensic psychiatrists may specialize exclusively in legal issues, almost all psychiatrists may at some point have to work within one of the many areas in which the mental health and legal system overlap. And so what this is kind of getting at is basically, no matter what, if you go into psychiatry or mental health care in general, you will be grappling with that interface of psychiatry and the law pretty much all the time. Forensic psychiatry is like the subspecialty that addresses kind of specific issues, and we'll talk about that. But just to go through some kind of general legal issues that will come up, let's say if you go into psychiatry residency, even if you're in like primary care, taking care of people with mental health issues, but really in psychiatry residency as well, you'll be coming across a lot of these issues. And so involuntary hospitalization, particularly in psychiatry residency. So that's kind of the pinnacle of what we often think about of psychiatry and the law, right? Is taking somebody against their will, or somebody who kind of doesn't understand what's necessarily going on, and putting them in the hospital, right? And so that is a very, very common, particularly in beginning of psychiatry residency training, working in emergency departments, working in locked psychiatric units. That's often how many training programs start people out. And so that's kind of a very striking introduction to legal issues in psychiatry. Other things that you might look at, let's see if this goes forward here. Oops. Being buggy. So civil commitment proceedings, that's kind of linked with involuntary hospitalization, but that would be, for instance, testifying. So I didn't realize this when I went into psychiatry residency training, but in many cases, someone might be put on an involuntary legal hold for like danger to self, danger to others, what we call grave disability, if they like can't take care of themselves because of mental illness. And so that might last for maybe a day, a couple days, things like that. But if it lasts longer, and if people are typically, and it depends on what state you're in, there might be a legal hearing in which you might, as the doctor in the hospital, testify as to whether the person should be in the hospital or not. So those are civil commitment proceedings. Suicide and violence risk assessment. So this is kind of pretty much almost every patient encounter. This is something that you might be thinking about, right? And that kind of links with, do people need to be in the hospital, but also a lot of other things, firearm restrictions. What are other ways in which keeping people safe? When do you report kind of threats of hurting other people? So all of these kind of interfaces with psychiatry and the law are very common. Informed consent. So what are the treatments you're doing, whether from just kind of basic treatments, some medications, all the way up to, electroconvulsive therapy or, things like that. And decision-making capacity, particularly if you're going to be on what's called like consult services. So that'll be seeing people who have delirium, people with dementia, complicated medical issues. Do they understand kind of the decisions that they're making? So these are all, again, just things that you'll be doing kind of no matter what in your clinical practice if you go into psychiatry. Medical malpractice is something that you will see and talked about in your training, but also just thinking about like, what's the standard of care? Like, what should I be doing in these situations? And other kind of last one, so disability paperwork or accommodations, that's something you might come across in a lot of psychiatry training. So people coming in asking for accommodations on tests or disability paperwork related to benefits or their jobs or things like that. Okay, so that's kind of no matter what, if you go into psychiatry residency, you'll be encountering those types of topics. What is forensic psychiatry? Like, what does a forensic psychiatrist do, right? And the spoiler alert is a lot of different things. There's a lot of different options, but different people will take different approaches to this question. This is just how I just kind of, in a very quick introduction, would view, if you're just learning about the field, what are some big categories to think about? So the first would be forensic cases, like doing forensic work at the interface of psychiatry and the law, like answering legal questions or helping courts or legal officials. The second, which we'll go through, is clinical care, like providing care to people in what are called like forensic or criminal settings. And then teaching is kind of a really big part of the field. Okay. Sorry, my screen's being buggy here. So this is basically how one might divide forensic cases. So what are forensic cases? Basically, this is one potential role, a big one. And this is what a lot of people typically think about when they hear of like a forensic psychiatrist. This is somebody like getting cases from like a court system or something like that. One way of viewing it is criminal or civil cases. Other people would add additional categories like child or different things like that, family court. But a big divide is really criminal and civil. And so the distinction here, criminal, is typically when people have been like accused of crimes and in some way that mental illness is coming up in terms of questions for the legal system of how did mental illness relate to the crimes? How does it relate to punishment? How does it relate to should they be found guilty or not? Things like that. And civil is much more related to like people having wrongs against each other, like lawsuits or in the work environment, accommodations. And here, let's go through some examples. So for instance, for criminal, so one topic is competency to stand trial. So basically, it's the court systems, as well as just kind of ethically and philosophically, it's been kind of deemed that it's kind of unethical to conduct a legal proceeding with somebody who doesn't understand what's going on, right? If somebody is so sick and so ill that they're kind of hallucinating or have delusions and they don't understand the court proceedings around them, like what's the point of trying that person? And so competency to stand trial, they might ask forensic psychiatrists or people with training to come in and evaluate, does this person, are they able to understand the proceedings that are happening? Are they able to assist their attorney? And so that's an example. And so that's typically like if someone's been charged with a crime right now, do they understand the proceedings? Not guilty by reason of insanity typically looks backwards. And this is probably one of the most like misunderstood topics in forensic psychiatry. People think the insanity defense is some sort of get out of jail free card. But really it's one, really rarely brought up, and two, incredibly difficult to meet the legal criteria. We don't typically diagnose people as quote unquote insane. That's a legal determination as whether their mental illness met legal criteria to be found not guilty by reason of insanity. And so that would be at the time of the crime. So when somebody allegedly did something, what was their mental state? Whereas competency to stand trial, regardless of what their mental state was at the crime, now do they understand what's happening? So that's a kind of a common mix up. Mental health diversion is kind of spreading across many states, where basically if people meet certain criteria because of their mental illness, are there ways to divert them away from jail and prison? And so they might ask for evaluations regarding that. And then sentencing, that's another example where let's say somebody committed a really horrific crime, they're potentially facing the death penalty or something like that, or a life sentence. They might have an evaluation done for aggravating or mitigating factors, right? So mitigating factors might be Do they have a history of mental illness, history of trauma, other factors that should be considered. So again, this is like a super duper brief overview of crime. Like there are so many different categories we're just not even going over, but these are just some brief ones. Similarly for civil cases, so medical malpractice is a big one that people think about. So let's say something happens, somebody sues a psychiatrist or a facility for malpractice, and basically they might call a forensic psychiatrist in to come in, read the records, evaluate the circumstances of what happened, and then they might provide an opinion about whether or not the person or kind of facility like fell below the standard of care. Testamentary capacity is if somebody has the ability to make a will, like if they understand what they're doing when they're making a will. So you might have like contested kind of inheritance type stuff. Fitness for duty, that would be an example of if somebody is posing a threat in the workplace or if they're not able to be accommodated in the workplace because of mental illness or something like that. And then personal injury, an example might be, let's say you're driving your car, you get in a car accident with someone, 6 months later, they have developed post-traumatic stress disorder. They might sue you as a result of the post-traumatic stress disorder. And so they might hire experts on both sides to potentially evaluate what's going on. This is what people might think what forensic psychiatry, this is kind of what comes up is like the expert sitting in court testifying. This is an image from the Aurora shooter case, which had lots of headlines, New York Times, things like that. This is a psychiatrist testifying here about whether or not he met specific criteria for mental illness or the insanity defense or things like that. But this is what a lot of people think about when they hear forensic psychiatry, like sitting in the witness box, providing expert opinions. And so that's like a part of forensic psychiatry, but it's really just like a tiny, tiny part. Basically, the vast, vast majority of what you're doing, if you're doing forensic cases, is like one, reviewing records. So when I started fellowship, and we'll talk about the training pathways later, getting thousands of pages, everything from just endless vital signs to medications that were administered to all of these records from hospitals that you look over really, really closely to figure out whatever legal question you're answering. And that helps conducting evaluations. So that's whether now with the pandemic over something like Zoom or remotely or in person, going to hospitals or in the community and evaluating somebody, doing testing, doing an interview, writing reports. As there's a forensic psychiatrist, Phil Resnick, who talks about how like that's kind of the bread and butter of what forensic psychiatrists do, is kind of records review, evaluations, and then writing a report, which then is given to the court. And that's kind of the main function that we often have of providing our opinions and kind of the basis for them. Communicating with attorneys and court officials. And then I added the ... to be like, all the way at the bottom is like once in a while you might testify in court. But really, if some people who I talk to who are interested in forensic psychiatry think that every day they're going to be, on CNN or something testifying. And, I would say that would be the wrong reason to get into the field. And we can talk about the kind of different, later about, why I joined the field and kind of why I think forensic psychiatry is very interesting. But again, the vast majority of your work is really digging into these legal questions comprehensively, and testifying is often kind of a last resort for the court system and really might just be a small part. So I went through the first part, forensic cases, and so that's what people often think about with forensic psychiatry. Clinical care is another part of providing care in kind of secure settings. So these are a couple slides. I did a talk at UCSF, which I believe might also be on YouTube, about mass incarceration and mental illness, and I borrowed a couple slides here from that. And so that kind of goes much more in depth into the problems of mass incarceration and mental illness if you're interested in that. But here you can see the dramatic rise of the prison population in the United States over recent decades. An important part is the distinction between jails and prisons. Jails are typically where people are held often when they've been charged with crimes, not necessarily convicted and waiting kind of for trial or a guilty plea or any sort of plea bargain or something, but basically it hasn't been adjudicated yet. And so often they may be there anywhere from days to months to sometimes years, but typically we think of jail as like a year or less, and then prison we think of as like a year or longer, where people have been sentenced and kind of sent to prison. So this is just the prison population. I sometimes think about jails as kind of like an emergency department or urgent care, like very rapid turnover, lots of people, and prisons is much more like a long-term care facility. So like much longer stays. That's kind of just like an analogy. Lots of mental illness in US correctional settings. This is just one systematic review looking at the prevalence of mental illness. And again, in state prisons, so that's one thing to think about, prisons versus jails. And you can see pretty much every single mental disorder here, ADHD, bipolar disorder, anxiety disorder, generalized anxiety disorder, major depression, PTSD, schizophrenia, like pretty much all of them higher than in the general population. And this is a report from the Treatment Advocacy Center where they basically said that the LA County Jail, Chicago's Cook County Jail, and New York Rikers Island Jail Complex each have more mentally ill people than any remaining psychiatric hospital in the United States. And so I think that's something we don't learn about a lot in medical school or in residency training. We think about the front lines of mental health care as, academic medical centers and kind of where we're going to medical school. And don't get me wrong, there are amazing clinicians and mental health care provided in those settings as well. But the front lines of mental health care are in many ways in jails and prisons in the United States. And I think that's something that the medical community, we need to do a better job of acknowledging and doing something about. This is what it might look like, right? Working in a jail or a prison where people, this is a documentary actually from PBS, which I would recommend checking out about solitary confinement and what that does to people. But this is very, very different than what we see in medical school, right? Where people are wearing white coats and rounding around computers that kind of move on wheels, and there's, nursing stations, and we're in the hospital. This is a very, very different environment. And yet I would contend that if you are looking for where people would need people who are marginalized populations in terms of unhoused individuals, substance use disorders, addiction, severe mental illness, this is where I think we need to be. And this is where there are so many people with unmet needs. And so this is in forensic psychiatry, people sometimes will call correctional psychiatry. And that's kind of like a sub-branch of forensic psychiatry. And that's what I do primarily in my work, is working in the San Francisco County jails, taking care of patients. And that's what I kind of do in my day-to-day basis in addition to some of the other roles. With correctional settings, we often focus very heavily just on jails and prisons, but there are many other environments, secure environments, where kind of forensic-esque people may be working. And so state hospitals or forensic hospitals are another setting that we don't talk about, or I really didn't learn about in medical school at all. And so this is a photo that I found on NPR about Napa State Hospital. So that's just one example here in California of the Department of State Hospital system. But this is what Napa State Hospital, this is one entrance at least, right? Where this was on the NPR article, but this is not what a traditional hospital looks like, right? And so a forensic hospital is typically when somebody who has some sort of like criminal legal involvement related to their treatment needs, and they go into a hospital setting. So for example, if you might wonder, hey, you were talking about people who are competent to stand trial or like what happens if they're incompetent to stand trial? Like, what do we do with that, right? And so in many situations, if someone's incompetent to stand trial, they may be sent to a state hospital where they are treated, sometimes against their will, sometimes not, but they'll be treated there until they regain competency to stand trial, and then they go back into the jail system. And so that's an example. People found not guilty by reason of insanity, they might be transferred to a state hospital until they're treated to the point where they're either no longer really have signs of mental illness or they're no longer dangerous. And so these are typically high security settings. And I know like safety is kind of often what comes to the first of people's mind when I have medical students in the jails or in the prisons. I personally feel very, very safe in these environments where there's a very high focus on security, where there are staff there. It's very just well known. It's just kind of a overwhelming focus, almost too much sometimes. But the only times that I've ever really kind of felt unsafe really in my training so far, at least, has generally been when I've worked in non-jail or forensic settings, which has been like the emergency department, where people, you don't really know them that well. They might be intoxicated. There's not really much security staff who might be around. It's the middle of the night. And so that's something I think is important to think about as we think about these different locations. And because that's kind of a common thing that will come up is people's kind of perceptions of safety. Okay, so we talked about correctional facilities, forensic settings, and teaching would be, I would say, is a really important role in forensic psychiatry as well. And that can take many forms. One is there are forensic psychiatry fellowship programs like across the country. There's dozens of them. And so here in the, so Apple is kind of what we refer to as the American Academy of Psychiatry and Law, but they have a list of all the fellowship programs. And so depending where you are, may have one. And so that's an important role as faculty who do teaching related to legal issues, who will teach fellows, but also teach medical students, residents, things like that. And so, yeah, fellowship programs are, across the country, and that's a really important role. But also in other contexts. This is just an image of kind of a grand rounds type setting at UCSF talking about legal criteria, right, for people who might be placed on involuntary holds. But whether it's at grand rounds, whether it's at APA conference, or even giving talks, many forensic psychiatrists might give talks to like lawyers or sheriff's associations, or educating the courts or speaking with judges. So teaching is very much seen as an important role in forensic psychiatry. And I think that's often an important thing to think about. What does the training pathway look like? So this is kind of like the typical pathway. I know some people leave and they do an MPH and they come back, or they do child fellowship. So, okay, I know there's lots of variations, but this is like just the generic, like straight through, medical school, as 4 years generally, general psychiatry residency, generally 4 years. And then fortunately, forensic psychiatry fellowship is not like, some infinitely long training. It's 1 more year. It is possible to do forensic work without fellowship, and that's something I'm happy to talk about. Some people testify in court who have not done fellowships. There are people who work in jails and forensic settings who have not done them, but it can also be a very, very helpful experience to see those different settings and kind of decide how you might want to integrate that into your professional career. This is an article in case you're interested afterwards in terms of for reading, but this is about applying for forensic psychiatry fellowship and what that looks like. And they kind of have a table here about like year by year things to think about as you go into psychiatry training. This was a publication, I think, in Academic Psychiatry. And what can you do as a student right now, right? If you're saying, well, okay, maybe I'm interested in forensic psychiatry, but I don't know, I want to get some more exposure. So one is an elective rotation. That's something to think about. Not only your home institution might have opportunities, whether that's working in a jail, whether that's an actual forensic psychiatry elective, or doing an away rotation. I'm not sure how those are working depending on COVID, but there's schools that have away rotations. At UCSF, we have one for forensic psychiatry. I know NYU has one. That was my first exposure to forensic psychiatry, really was an away rotation in New York City. You could attend an Apple meeting, so the American Academy of Psychiatry and Law. They often have like discounts or ways for students to attend, and just attending the talks and seeing what that's like. Also, because of COVID and the increase in kind of video, Zoom and things like that, they're also having kind of intermittent talks throughout the year. So there are like kind of 1 hour, evening talks or things like that you can kind of hop onto, and you could email the Apple office about how to get connected with those. Adding on the Journal of the American Academy of Psychiatry and Law, people call it JAPL. And so you can sign up for like the email alerts. So I get those in my email. They're quite helpful. Like when a new issue comes out and reading through, and some topics may not be, what you're necessarily interested in, but other topics you may not have thought are super interesting. And it covers everything from, death penalty, PTSD, competency to stand trial, providing clinical care, artificial intelligence and risk assessment. There really are very interesting articles to read through. Collaborating with residents or faculty. So at your institution, there may be people with forensic training or who do this kind of work. And so working with them on some kind of interesting research project. Or if, you're really stumped and you're saying, hey, I really am just not sure at all. I think it's always straightforward to contact somebody if there's a psychiatry residency program at your institution, or if there is somebody, a faculty member with forensic training, just kind of contacting them saying, hey, I'd be interested in kind of learning more about this, or, taking the time to chat. So these are some opportunities for reading as well. So there's the JAPL, the Journal of the American Academy of Psychiatry and the Law, and their website is online. And then here are just a couple books that might be of interest. So Sometimes Amazing Things Happen by Elizabeth Ford. She was a head of the New York City jail system, the psychiatry service there, and also led the forensic training at NYU, and writes about her experiences coming up through training and through residency and then forensic practice in the New York City jail system. While the City Slept is an article about a crime that was committed by a young gentleman, and then basically the aftermath of that, and also how it kind of reflects the many ways in which our mental health system is broken. And it kind of dives into the court process, what that looks like, how mental illness relates to his criminal case. And then Waiting for an Echo came out, I think, in maybe the last year or so. And that's by Dr. Christine Montrose, about American incarceration and kind of the degree of mental illness in the US correctional system, and kind of what that means for how we take care of people with mental illness. And she gives examples of different jails and prisons that she's visited. So those might be different kind of items of interest for you. Yeah, and so that's again a very, very brief introduction to the field. I could talk for a very, very long time, but I figure I'll shut up now. And if anybody has any questions, I'm happy to chat further or to answer
any. Feel free, guys, to unmute yourselves and ask questions. If nobody has questions, then we can kind of go through the ones that were submitted, but I'll let you guys go ahead. All right. I guess one common question has been, why did you choose your specialty? And what did that look like, that your career trajectory look like into forensic psychiatry?
Sure. And so for me, at least, I think, and this is probably universal for anybody picking whatever specialty. I know it sounds like your group kind of has different people visiting from different specialties. And I would just say over time, as you go through kind of different, whether it's medical school rotations, or if you do go into psychiatry, different training rotations, really paying attention to what are the kind of clinical stories, or what are the areas within psychiatry that really draw your interest and that really kind of capture your interest, right? And so, there are many different, psychiatry is such a wide field with so many different opportunities. But I think over time you might learn that there are specific kind of subsets that will really draw your interest. Hey, this person's up, who's going to be taking this admission? And when you find yourself kind of really, oh, hey, this is one that really interests me, or cases that you're reading about that really just kind of stay with you, right? I would just say over time, the ones that really attract your interest. And for me, that's what happened with forensic psychiatry over time. I had initially had an away rotation at NYU, working at Bellevue, their hospital there, where they have a forensic jail unit typically for people from Rikers Island who are so kind of ill that they kind of need a higher level of care, or people brought in kind of by the NYPD. And that was a really, really kind of eye-opening experience for me, because most of my medical training so far in medical school had been anywhere from like lectures to clinic to some sort of hospital setting, right? And to see a kind of unit run behind bars, in many ways run by, custody staff with people who are incarcerated, it was just such a different environment. And to really see the degree of illness in that setting really kind of opened my eyes. And then going into residency training, as I mentioned, with kind of what are the things that kind of capture your interest. I really, for me at least, the interaction between psychiatry and the law was really what I personally found to be the most compelling part of training. Of, in addition to kind of patient stories, just what is it like to sign a piece of paper so that somebody is held against their will in the hospital? Like, that is a really profound thing to do, and with so many pros and cons and so many ethical considerations there. What is it like to sit down as a physician and to testify with your patient sitting there, saying that they cannot make decisions for themselves, and that you know better, or that your recommendations will save their life, when they are adamantly disagreeing with you, and to testify and to say that I think that this person should be in the hospital against your will. These are really, really, in many ways, kind of heart-wrenching decisions, but also I just found myself fascinated kind of reading about the history of civil commitment, kind of these legal issues. And then over time, increasingly found myself, given the degree to which people who with mental disorders and substance use disorders are criminalized, like how many of them had criminal legal histories, found myself drawn again towards the correctional system. And so that's kind of a brief rambling answer, but that's kind of how I found myself where I am now. Yeah.
Somebody submitted a question asking, Would you say a fellowship in forensic psychiatry after general psychiatry is necessary to enter and be successful in the field?
So it's a great question. It's something I get quite a bit when we have medical students or residents with us. As with most questions in medicine, the answer would be it depends, right? And so all of that depends on multiple factors, right? And so the first thing is, what does it mean to be successful in the field? For some people, to be successful in the field means, doing big cases where they're working on very, very high profile forensic cases where they're testifying in court or working with the federal government or things like that. Like that might be some people's goals. Other people's goals might be academic writing, right? Like really diving into legal questions related to psychiatry and the law and writing and publishing research or, academic writing. Other people may be shaping policy, right? So advocacy, rethinking conservatorships, rethinking civil commitment, rethinking criminalization of people with mental illness and addiction. And so there's many different, other people just providing care in these settings, right? Taking care of people in secure settings. And so obviously the first part of it depends is just, what does it mean to be successful, right? It really depends on your own interests and your own kind of goals. The other thing I would add is it really depends on the individual person, right? So some people who go through training and they decide that they're interested in forensic work, but they're already maybe in their 40s or their 50s or even their 60s and say, hey, I want to start doing, forensic work. If they have a family and they're super busy and they really don't want to go back into training again, they may say, hey, 1 year is a lot of time for me and I might not want to do that, right? Versus somebody else who's kind of just finishing up their training and they're not really sure where in the field they want to practice and they're really interested in getting an in-depth kind of training. They may say, hey, absolutely, this is for me. My experience with forensic psychiatry fellowship was that I thought it was an amazing experience, not only getting to work in criminal cases, civil cases, working in prison settings, taking care of patients in many different settings. And so we got to see all those different environments and then also to learn from people who have gone through, not only in clinical context, forensic context, teaching context, but just to absorb all of that learning and then to use that moving forward. I learned a lot. And you can often see when people who are writing reports or testifying or working in certain settings, if people have had forensic training or not, you might sometimes be able to tell just based on kind of the work that they're doing or the style, or you might see people at meetings, right, and say, hey, they're at the Apple meeting or something, and kind of get to know them over time. But some people might say you absolutely have to, be board certified in forensic psychiatry, like, the subspecialty board in order, and that's not necessarily true. And in many cases, you don't need it. And the most important thing, if you are going to be writing reports or testifying, is that you have experience in this area and have a basis on which to make these kind of opinions and things like that if you're going to be doing forensic cases. So, still seeing patients, having experience with the type of mental illness or mental disorders that you're kind of providing opinions on. So the long answer would be, do you 100% absolutely have to have it? No, but it is very, very helpful and very it is very important on specific roles. So particularly if you're going to be teaching in forensics fellowships, if you want to use that board certification in different ways, whether that be testifying, academic, things like that.
Great, thank you so much for that. Another question that was submitted was, what would you say is the most exciting part of your career in forensics? And then what's something that's more boring or more daunting, something that I guess you're adjusting to?
I think, there's lots of different examples in terms of the excitement of, obviously, testifying in court for the first time is a very, it's nerve-wracking is probably a better word, but there's obviously very exciting moments where if you are picking up cases that are very, very interesting, high profile, kind of criminal, those types of cases, the work is super intellectually stimulating. You are often getting access to medical and legal records that many people do not get to see, that you are really kind of privy to, and that your opinion is something that could sway what might happen. There's lots and lots written in the Journal of Apple that you can look into about many of the pitfalls that people fall into with forensic work, thinking that their opinion is the be all end all and they're the superstar of the show and things like that. And that's obviously very important to think about as you do this work. What are some of those pitfalls? But as I ramble along here, what I might kind of, to answer the question about what would be, the most exciting for me, at least, is particularly working in jail and prison settings, is I think working in a place that many people have never stepped foot in, and many people have kind of misconceptions about and are quite frightened by and do not know about, right? And so working behind those bars with people who have been accused of crimes, people who lead very, very different lives in some cases, where they may be in solitary confinement for months or years at a time, where they may have been accused of really, really horrific things. I think that kind of world is not often talked about in the medical community. We don't get much training in that. And Elizabeth Ford, who had written that book, she had written an essay, a while back, where I'm totally going to butcher the quote, but she said something along the lines of, I talk to medical students and residents from the perspective of someone who has ventured into the secret spaces where we put the people that we fear, right? And so to me, I think that's, one of the most exciting parts is to be able to go into those settings and to be able to help the people in those places who often are either so stigmatized or looked over or ignored. That to me is very exciting about the work. In terms of the boring part, I mean, I can only just think of electronic medical records and documentation. That's in like the clinical part, but I mean, that's just, it's really just taking over medicine. And, even today, I was seeing patients today at one of the jails, and, as we sat in the room, me and several other providers, and you can just listen in the silence, and all you hear is just the typing of keyboards, right? And so I would say that would be, and I don't think that's unique to forensic psychiatry, but that's something that definitely weighs on you over time, as you might see someone for X number of minutes and then really have to just document, endless amounts. And that's always kind of always a struggle. But again, that's any field. So welcome to medicine.
Okay, great, thank you. Let's see, where in the workforce can we find a physician with the area of expertise in forensics? And the follow-up is, what are some frequent cases that you see? And I think you touched on this in your presentation a little bit, but just wanted
sure. I mean, the first thing I would say is, if at your medical school you can just search and see, is there a forensic psychiatry fellowship? Like, that would probably be step one. And if there is, then that probably means there's quite a few people with forensic training and forensic experience there. And if you're interested, I would reach out to the director of the fellowship program and say, hi, I'm interested in learning more about the field. Would you like to chat sometime, or what might be some opportunities as a medical student? So that would be the kind of first kind of straight shot, would just be if there is a forensic psychiatry fellowship at your institution. If there's not, there still may be many different opportunities. So one, as I mentioned, looking through kind of elective rotations. Some schools have rotations in jail or prison settings where you could rotate as a medical student. You could also just search through the faculty. There are certain faculty at medical schools, even if there's not a fellowship, who will probably put, like, on their online profile or their research publications or whatever, their interests, which may include psychiatry and the law, forensic psychiatry, legal issues, things like that. So that would be another opportunity, is just reaching out. And let's say if there's no fellowship program, there's no rotation, you can't find any faculty member with any interests. If you have a psychiatry residency there, then reaching out to just maybe someone in that program, or the head of the psychiatry residency program, and saying, hi, this is something I'm interested in. Are there any faculty or people you might connect me with? And that might be helpful, because they can not only connect you with faculty who are there, but also they might know people who have graduated from the program and who kind of work locally and stuff, and be able to connect you with them as well. I forgot the second part of the question.
What are some of your most frequent cases?
Oh, sorry. Yeah. So I think we went through that a little bit in the talk. Again, it depends. I, for instance, right now, primarily, I'm just working clinically, taking care of patients in the jails. But you'll see, so for some forensic psychiatrists, they do just lots of competency to stand trial evaluations. Other people may do mostly civil stuff, a lot of basically disability evaluations or personal injury things. So it really depends on the person. short of people who are kind of very, very well established in the field, it would be a little more unusual to like every single weekend have like a new not guilty by reason of insanity case or like some, big case like that. But many of the mentors who I've had or people who I've known over the years might start out of fellowship, kind of taking kind of regular, like, lots of competency to stand trial, those types of cases. And then over time kind of build a mix of cases that kind of tailor to their interests.
Great, thank you. Just want to field questions again. If anyone wants to ask a question, feel free to unmute and go ahead.
I have a question. Thank you so much for sharing with us. I was wondering if you could talk about, do you develop long-term relationships with your patients?
Yeah, you mean in the jail or?
Yeah, in the jail.
Yeah, so it obviously depends on what the individual circumstances are. So I would say, absolutely, we do have patients who have been there for months, if not some who have been there for years, where if their criminal case is proceeding particularly slowly, or some people are, they're seen initially, they become incompetent to stand trial, they go to a state hospital, they come back, or some people who are facing very, very serious charges, those can be very prolonged legal proceedings. So I'd say in general, yes, I have many patients who typically we see folks on follow-up visits and you kind of get to know them. Unfortunately, and this is kind of one of the sadder parts of the job, is you see people who are incarcerated repeatedly, right? And so not only during a particular incarceration where they might be there for a long time, but also people who kind of leave who are rearrested. And that's really challenging, right? Somebody who's just gotten out and you kind of will go and see them and you remember just a couple of weeks ago, you saw them and they've been released and they've already, ended up back in the jail for whatever reason. So that in the jail standpoint, that I would say is the kind of general context is, yes, we definitely do have longitudinal relationships, whether in the jail continuously or if somebody's kind of, incarcerated, unfortunately, on numerous occasions. But as I've kind of mentioned before, there are very many different contexts too. So for example, in the prison setting, so if somebody is, condemned, which is often called death row, or if somebody's on a life sentence, some clinicians might get to know them over years and really know a decade or more, right? Like get to know somebody very, very closely. And so the prison setting, given that people are there much longer, there tends to be much more, in my experience, having, seeing people, in terms of follow-up. But yes, we also have that in the jail as well. And then the forensic hospital is kind of, I haven't personally, been an attending in like a forensic hospital, but that's kind of much more like an inpatient type setting, but people still may be there for months or years. And so in those three settings, yes, you will have some degree of longitudinal care, yeah.
Thank you. You're talking about like patients' recidivism. How do you assess that? Do you help with like the parole hearings and stuff like that?
So parole is typically when somebody is going to be released from like a prison setting or from like a sentencing. So probation is often if somebody is facing charges at like the jail level, they might be put on probation and then released to the community. I think if you're getting at it, like do our clinical assessments like affect the court basically is decisions of whether to release someone or not? Is that kind of what you're getting at?
Yeah, kind of like that, yeah.
Yeah, so it's actually a really tricky part of our work where, technically we're not really representatives of the court. I'll say this to patients a lot, like I'm not like coming here on behalf of, when I'm not in a forensic role, right? Like if I'm just in my normal job taking care of patients in the jail, I'll just, hey, I'm just, a doctor here to making sure people are doing okay in the jail and, promoting people's health. But I obviously add that disclaimer that like really anything in your records or anything that's written, right, the court could like subpoena or look at, right? And so in general, it's usually not our job to just be like, you get out or you don't, right? Like that's usually like the court or, the DA or like their decision making. We're really just taking care of people and making sure that they're okay. But, as with everything in this talk where it depends, there are some circumstances, right, where depending on how somebody gets placed in a community program or like, are they on conservatorship or, what are the treatment opportunities for there are times where the clinical and the legal do overlap. But I would say in most situations, like should someone be released on an ankle monitor and stuff like that, like usually the court is making that decision. And it's actually really challenging for us clinically sometimes, because somebody who we have worked and we have a treatment plan and they're on medications, like all this stuff, and they may get taken in the morning and they go to court at some point, and then it's just like, okay, you can go now, and they're just like released. And so, how do we do discharge planning with that kind of stuff, right? So I would say in our experience, we try as best we can to really help integrate our care as a continuum for patients. But your question is really well taken, and something we often grapple with, right? Of like, what are our roles here? And there are definitely forensic roles where they might ask, like, as I mentioned with mental health diversion, they might ask for like a forensic expert to come in and write a report with the specific criteria of like, should somebody, are they amenable to treatment in the community? What's their mental disorder? Do they pose a danger? Things like that. I got a question in the chat where somebody said, how much of my job in the jail is therapy? Is it just med management? Or are we offering therapy to patients to deal with kind of everyday things going on? Yes, that's a great question. I think you can sense the theme here of it depends where. So in a prison setting, right, it's much easier where somebody's going to be there for potentially years to set up a therapeutic relationship and to, really kind of do CBT type stuff, long-term therapy, things like that. That's much more possible when someone will be here for years and years, right? A jail is often much more difficult, right? Where sometimes there are people who with very, very serious charges where you're like, we have a sense this person's not leaving for months or years. But otherwise, for many people who are kind of brought in on not super high profile charges, they could be released at like any time, right? And so that's not to say that we shouldn't provide care. Of course, we strive at all times. And to answer your question, are we just doing med management? No, we're doing way more than that. I mean, obviously, we are seeing, as the psychiatrists, we see people in many different roles, but at least in the San Francisco County jails, we have a very, very large team where the psychiatrists are just one small part of it. We have therapists and social workers and many other folks who really do a lot of the frontline work of triage and screening and stabilization visits and meeting with people. We're often, as the psychiatrists, we'll see people for a range of reasons, whether it's medication related, whether it's related to conservatorship type stuff, risk assessment. But yeah, I mean, obviously therapeutic, supportive therapy type things, meeting with people on a regular basis, establishing that kind of intensive follow-up. That's obviously a huge part of the role, doing lab workups, going through motivational interviewing for substance use, medications for substance use disorder. So this whole range. And so, I don't want you to leave this talk to think that people who work in jails and prisons are just like handing out SSRIs, which, I obviously can't speak for every clinician, but that's really, our role is, I do much more comprehensive. I hope that answered the question. I see someone with a hand raised.
Yeah, I was just curious, in terms of like juvenile detention centers, typically if there's like mental health care needs there, is that something where like a child or adolescent psychiatrist would be handling kind of those people in those settings, or is it something like, a pediatrician obtains additional psychiatric training, or what do you typically see kind of in more juvenile care settings?
Yeah, that's a great question. So I haven't worked in a juvenile detention center, so I obviously huge disclaimer here that do not have much expertise in that area, but I have done some child forensic cases, and I would say in general, my understanding and my experience with the juvenile system is that they really do as much as possible to keep people in the community with their families and not detained. At least what we were taught in our experiences in fellowship is that basically every effort should be made to keep someone in the community, short of really extreme, like very, very serious, like violent crimes or other reasons why someone might need to be detained if they're under the age of 18. And in those situations, typically they should, but again, I haven't worked in these situations, have access to adequate pediatric and psychiatric care. to your point about child and adolescent psychiatry specifically, there is like a huge need for more experts who have training in that in the forensic realm. So courts like across the country are really struggling in terms of access to experts, because even if you have gone through medical school, residency training, forensic fellowship, even at the end of that, and that's somebody who is like very, very, very subspecialized, they may not feel comfortable doing a competency evaluation in kids, right? So even that is very, very different. What is the role of like intellectual disability, right? Neurodevelopmental disorders. These are really, really important questions. And in my experience, the forensic child cases that I did, at least through fellowship, were almost universally just really heartbreaking, where it was really challenging all around, just because you have someone who's so young and has facing potentially really serious consequences. These are really challenging legal questions. So yeah, at the end of the day, we definitely need people with more child training in the forensic field. And you will see some folks who have like double boards in there, or I guess they're like triple boarded because they're like general psychiatry, child, and forensic. But yeah, I'm happy to chat more at another point, or give you some names if that's something you're interested in. Someone put in the chat, our forensic psychiatrists mostly seen in an antagonistic light by their patients, more so than in other psychiatry subspecialties. So a couple things. So one thing is first to distinguish the clinical role from the forensic role, right? And so the forensic role, if you're just coming in and doing an evaluation on somebody, that person is technically like not your patient, right? Like, and this is something we say before these evaluations is like, I am a doctor, I am a physician, but I'm not treating you. Like what I'm doing in this evaluation is I have been hired by insert, court attorney, whatever, to answer specific questions. Confidentiality does not apply here. Like what you tell me could potentially be included in a report submitted to the court, right? So it's very different. And that's something I often would catch myself if I was presenting to a supervisor in fellowship, where I would refer to someone as the patient, right? But it's very important to recognize that this is someone you're evaluating for a forensic purpose, that they're not your patient, like you're not treating the person. But in a correctional setting, or a forensic, hospital type setting, if that's what you're getting at about kind of, I would say it goes in both directions. Some people are absolutely thrilled to see you because they are incarcerated, they're in solitary, administrative segregation, which is kind of the phrase used for solitary confinement. They, really need to be restarted on their medications, or they're suffering, or they're withdrawing from substances. And some people are absolutely delighted. Oh my God, we have mental health care. And I think in the San Francisco jails, we're fortunate where we have a team of, what I think are awesome physicians from UCSF providing care. So some people are thrilled. Some people just kind of, hey, okay, doctor, refill the medications, or kind of see us and, whatever. And then some people, yes, are antagonistic, or they are not happy to see you. Why would you work in a place like this? Or are angry over, we don't provide certain medications because of restrictions in the jails, or, why haven't you told the judge to get me out of here, and things like that. And those, I would say can be challenging. I think to the question, is it more antagonistic than other specialties? I would say not necessarily. I mean, emergency psychiatry is very, very challenging, right? Where people are being put on legal holds, they might be intoxicated. Inpatient psychiatry, people are in locked units, right? You're testifying, even in clinics, right? Where you have like maybe 25 minutes with someone, and they have such a complex and nuanced life, and trying to get their entire life, updates from the last 2 months that they haven't seen you in 25 minutes, or if they have disability paperwork. So I think each setting has its own challenges, right? And I think it's up to you as you go through your rotations, determining which balance of challenges is most important to you.
Great. So I just want to say we have about 5 more minutes left. I do have one question. I don't know how familiar you are with like nature-based therapy and its use as like a diversion program, more so in like the juvenile setting. I know you said you haven't really worked with children or the youth population, but have you heard about it? And if so, what have you heard about its benefits?
Yeah, so I've heard of those programs sometimes where rather than particular types of punishments, or someone might they go on like a wilderness type trip or things like that. Again, I can't speak. I don't know about the effectiveness. I can't speak to that. I've definitely heard of them. To jump off a little bit from your question, though, I do think one thing that is a profound consideration, particularly in correctional psychiatry, is really thinking about the environment in which we care for people and that they're experiencing. And I think it goes in both directions. So for example, if somebody is feeling depressed, or they're not sleeping well, or they're really anxious, right? And part of that is, do I think that's mental illness? Like, not necessarily, right? Like being incarcerated, being separated from your family, facing legal charges, like that can cause mood changes, anxiety, sleep difficulties, right? Those are really, really stressful things. On the other hand, does that mean that we ignore that, right? And like, do we treat it or not? And that's kind of a really, I think, on a case-by-case basis. And you might see this outside of forensics too, or somebody who is experiencing homelessness, or, is unhoused, they may be facing lots of difficulties, right? And like, does an SSRI like fix that, right? And so the question of like, if somebody's feeling depressed or their mood is down because they are grappling with housing, that's a really challenging question. But on the other hand, do you ignore that suffering, right? And so I think that's a very big component, at least just focusing on correctional psychiatry, is just how does the environment in which someone that they're inhabiting, how does that affect their presentation? And that has other consequences in psychiatry too, saying that, hey, they may feel that the police, have it out for them, right? In some contexts that may look like paranoia, some contexts that very much may be reflective of reality, or other people in the jails or the prison, or somebody around me is trying to hurt me, right? That very similarly. So I think context is very important. And I know you asked about like nature-based programs, but that's my tangential answer there. So yeah.
Thank you.
I don't know if anyone, I think there's a couple more minutes, but I don't know if anyone has any other questions. Yeah, happy to answer any. All right. I've scared everyone away from forensic psychiatry. That's fine. Okay, well, yeah, it's been a pleasure meeting with you all, and I think my email's on like my UCSF profile or whatever, but yeah, you're welcome to email me at any point, and happy to chat if you have further questions. I see someone's hands up, actually, Christina.
Hi. I wanted to ask to you about if you have ever had the experience to be a police consultant, or have you only worked, or is it something that forensic psychiatrists are able to do with their degree?
What do you mean by police consultant?
I don't know, like working alongside, not more in the prison system, but like catching bad guys, or like helping them build profiles, or is that something completely different?
Oh, yeah. So, I thought, so you mean like Mindhunter or something like that. So I thought of putting, I thought of putting the book Mindhunter on that list. It's a really interesting book. I recommend it. But so two things. So, and I know we need to wrap up, so I, in my experience in forensic psychiatry, I have not really had much experience with like criminal profiling and things like that. I think a lot of people hear forensic psychiatry and they immediately think like Mindhunter, like you're like meeting with a serial killer and like, writing some sort of profile about them. Usually it's much more kind of like, here is a legal question for the court, and can you assist us with that legal question? There are people who do that kind of stuff. And then outside of kind of correctional context, I think, as you're alluding to, like police departments, there are people with forensic training or forensic psychiatrists, or psychiatrists with these interests, who will do talks with like police departments, or participate in like crisis intervention training, or how police departments might interact with like hospital systems or the broader community. And so there are ways in which forensic psychiatrists can kind of liaise in those ways. Yes, Mindhunter is an interesting book to read.
Thank you.
Sure. Looks like the time is up. But again, it's been a pleasure meeting with all of you. And absolutely, you should. Forensic psychiatry is fascinating. Feel free to reach out. So
Great. Thank you all for being here. Thank you, Dr. Morris, for sharing your evening with us. We'll hope to catch you guys at our next session. Have a great night.